Hi, I'm Dr. Abraham Morgenthaler, and I want to give a quick um, summary review and maybe a little bit of an overview of the Traverse trial. The results were announced on June 16th, 2023. And this was a large cardiovascular trial that attempted to show once and for all whether testosterone therapy was associated with increased MACE, major adverse cardiovascular events. And the bottom line is that it did not. So what was this? We've been waiting about 5 or 6 years for this study. Um, in the end, they took over 5,246 men and randomized them basically to testosterone gel or placebo gel. They all had to have levels of testosterone on 2 occasions that were less than 300 nanograms per deciliter. They had to have some symptoms, so they had the true condition that we call either testosterone deficiency or hypogonadism. And they all had to be at increased risk for cardiovascular events, either with known prior cardiovascular events or conditions like diabetes and hypertension that put them at higher risk. Men were 45 to 80 years old, and this was a non-inferiority type study. We don't need to get into that too much because, as you'll see, even if we forget about non-inferiority as a statistical concept, the numbers were almost identical or still very similar in both groups. And the primary endpoint was death from cardiovascular cause, or a non-fatal MI or a non-fatal stroke. And there was a secondary endpoint, which was the same, but they also added in coronary revascularization. So mean duration of time on treatment was 21.7 months. Mean follow-up was 33 months. And the number of major adverse cardiovascular events, MACE, was 7% in the testosterone group and 7.3% in the placebo group. Almost identical, slightly less in the testosterone group. And there was no difference for any of the component endpoints, such as stroke, heart attack, or fatal cardiovascular disease, or revascularization. And interestingly, prostate cancer was almost the same in both groups. 12 cases diagnosed in the testosterone group and 11 in placebo. Mean blood pressure increase, systolic blood pressure at 6 months was trivial increase of 0.3 millimeters of mercury in the testosterone group. So what do we make of this? I think the thing to take away from this is there was no difference. And it's just amazing to me. It's been a 10-year story of why this issue even came up. And I have to tell you that for about 20 years before all of these concerns, the evidence was becoming more and more clear that, if anything, low levels of testosterone should be considered a risk factor for heart disease. Any number of observational trials had shown that higher rates of atherosclerosis, higher rates of coronary artery disease, greater severity of coronary artery disease were all associated with lower levels of testosterone. Low levels of testosterone are known to increase fat. It's associated with metabolic syndrome. It's associated with type 2 diabetes. And we know that testosterone therapy reduces fat mass, increases muscle mass, and has been shown to have some beneficial effects on glycemic control, all of which would seem to be beneficial, if anything, in terms of cardiovascular disease. So where did this idea come from that there might be a concern? In 2010 was a study that had all sorts of, it was a placebo-controlled study in older men who had mobility issues, and there were more cardiovascular events in the testosterone group than placebo. But the vast majority of those cardiovascular events were sort of, as my kids would say, they were random. Like it was all these things like hypertension, non-specific changes seen on EKG obtained for whatever reason, PVCs on EKG, and there were only a couple of major events. So that sort of, people paid attention, but not that much. It didn't mean too much the way it was played out. And then in 2013 was really the big event, and it was the paper that the first author was Vigen, V-I-G-E-N, and co-workers. It was published in the Journal of the American Medical Association, arguably one of the most important medical journals in the world. And it was observational. It was from a VA population. And what they found was that men who ended up amongst men with low levels of testosterone, all of whom had gone through coronary catheterization, that was their population, that men who ended up getting a prescription for testosterone, they reported initially had a higher absolute rate of heart attack, stroke, and death than men who never got testosterone. This made huge headlines. New York Times had an editorial based on this, saying we're like giving testosterone cavalierly, and there are risks for this, obviously. Some of the legal firms decided this was a good basis for a class action suit, and were advertising on television, newspapers, everywhere. You could see it everywhere. For you or a loved one, have you or a loved one had a heart attack or stroke while on testosterone? And big headlines. And amazingly, and the FDA then had a advisory committee meeting, and basically the upshot of all that was that they didn't really have any evidence that it was a problem at that point, given the quality of the evidence they had. But it actually spurred on this particular trial, which is the Traverse trial. So the FDA made it mandatory for the testosterone manufacturers to create a cardiovascular trial and fund it, which is now what was just reported, which basically showed no increased risk, none. That study, what was amazing about the 2013 article published in JAMA, though, was that the authors had misreported their initial data. So they said there was a greater absolute rate of events in the testosterone group. That turned out to be an error. And the absolute rate of events was lower, almost by half, in the testosterone group compared to the untreated group. This was brought to the attention by some colleagues and myself to JAMA, and they changed the paper within a week, but it got no media attention. But their primary thing that they were looking at was false. What had caused all the trouble was false. In response to a series of letters, one of which was written by my co-authors, my colleagues and I, the authors reviewed some of their data set, and they discovered that 9% of their quote unquote all male population turned out to be females. Yeah, women. Now, that messes up everything. They didn't have a clean data set. I mean, that's sort of the most generous way of describing it. This was a somewhat careless study. When they reported that, 29 medical societies petitioned JAMA to withdraw the paper on the basis that it wasn't credible anymore. JAMA declined, and that paper still exists, and you can find it. And it can appear to be a paper that suggests there's increased risk amongst men who receive testosterone. It's not believable, frankly. And in the meantime, since 2013, 10 years ago, we've had any number of randomized controlled trials and many observational trials with large data that have shown that have failed to support the idea that testosterone therapy is worrisome for cardiovascular risk. Have failed to see it. So here we are now. It was sort of a new concept in 2013. It was based on bad data. 10 years later, we have a major cardiovascular study that shows, nope, not true. So hopefully this is the end of it. But there's always going to be skepticism. and cynicism. And, I was very involved with the prostate cancer story. That data looks like it's not true either, that higher testosterone is an increased risk for prostate cancer. It's been about 20 plus years of work trying to undo that. And we'll see what happens with the cardiovascular story, because once an idea takes hold, it's very hard to dislodge it. But that's the TRAVERSE trial. Those are my thoughts about it. My hope is that we never have to hear about this again. I think this is a definitive study. It's going to be hard to get 5,000 men in another study, and I don't really, in a randomized controlled trial for the similar purpose, and I don't really see the need for it. There's nothing that nobody's criticizing the methods of this or anything like that. This was done in conjunction with the FDA. So there we are, and I hope this has been of interest for you. Bye-bye now.